So this is a very interesting case. We had this 87-year-old woman who has been having leg pain and discomfort for months, never seeked attention, didn't get any care, and then in last 7 days, her right leg became cold and formed this gangrene, and she had an opening on the calcaneum on the back of the foot, and the dark spot that she has had for months now got worse, and some foul smell came out of it. So this is what I like to call acute on chronic critical limb threatening ischemia. The better analogy for this is the foot attack that we talk about, which is a person has chronic peripheral arterial disease, blockages, and then suddenly an event comes in and tips them over the edge, and now they may end up losing the limb because it's too late sometimes unless we really go and perform limb salvage angioplasty. And sometimes these limb salvage angioplasties are very cumbersome and difficult, as it turns out in our case. Fortunately, we got a great result. We use a new technology called shockwave lithotripsy. It's almost like lithotripsy that we do in the kidney stones, the technology is basically shock waves come out and creates micro trauma inside the calcium, because calcium is the enemy. This big peripheral arterial vessel sometimes have this chunk of calcium sitting in there, and if the blockage is in the thigh level or below the knee, we can do something called atherectomy, where we go and cut the plaque from inside. But when the blockage is inside the iliac artery, which is in the abdominal cavity, it becomes very difficult to do atherectomy because there is a risk of perforation. So this is where the shock wave comes in. So with that, I'm going to show you the films that shows this lady's thing. So as you can see, this is the catheter going in. We can already see the calcium. This is the distal abdominal aorta. It should never be this visible without any dye or contrast. This is the left iliac, and this is the right iliac artery, which has severe blockage throughout. So this is, as you can see, once we start giving contrast, the left iliac is opacified, but the right iliac will have no flow whatsoever. So as you can see, this is the left iliac. Again, there is a plaque buildup, but it's still vessel is sort of open. Another blockage here. Right iliac is nearly absent. There is no blood flowing there whatsoever. And part of the reason is there is this heavy calcific rock-like blockage. So what we do is we get access into this vessel under ultrasound guidance, pass a wire, and this is very tricky because you're going through complete occlusion. And when you go through complete occlusion, we can be in trouble because sometimes you can cause, really big problem, because you can cause perforation. Sometimes you can't cross the lesion. Fortunately, in our case, under ultrasound guidance, we could get access with multiple different wiring technique, and we could actually get into the true lumen. So now we are throughout this calcium range, and what we do right after that is ballooning. So you can see here, this is a ballooning picture. This is the catheter as I showed you, and then once we cross this, we inflate this balloon at low pressure and start applying lithotripsy, which is like pulse wave. Will actually help with creating micro trauma, which will allow our balloon to expand further, and then we got really great expansion on the left side, on the right side here, and then we also got expansion on we did the same thing on the left side. Right here you can see the left balloon we opened up. We did the same thing because there was so much calcium, and this is again on the left side you can see, and I'm trying to see this, and this is the simultaneous. So once you are done with ballooning, we go with covered stent, because part of the problem is once you balloon, there is always risk of rupturing the vessel, and if you rupture this vessel, you will bleed so much inside the abdominal cavity that it is impossible to save this patient. So what we nowadays do is go straight with covered stent, which contains any risk of bleeding. So this shockwave lithotripsy with covered stent has really changed the paradigm for this very serious iliac occlusions. So here's comes her. I'll show the final nice images that shows really great result. As you can see, nicely the stent is, you can see the blood flow is nice here. This was all occluded before, with kissing stent. So we got beautiful result in this too. We also ballooned this area and established flow. Unfortunately, this lady still has blockages in her femoral arteries. I want to show the femoral blockage. As you can see here, this is her knee joint, and the femoral artery has, previous picture shows it much better. This is the thigh. This is the superficial femoral artery, and you can see there is a lot of blockage still. Blockage here, blockage here. Below the knee tibial artery still has blockage, and this is in both legs. So once again, this is multi-vessel peripheral arterial disease. We got a great result with iliac, and now we're gonna stage her for her femoral and tibial, and hopefully we'll save this foot attack, which does translate into changing not only the foot and limbs, but actually changes into long-term mortality. Because if this lady were to get amputated, her mortality would be 25% at the end of 1 year and 50% chance of mortality end of 2 years. That's just what happens when people get amputated. Fixing this blockage now and allowing the wound to heal and preventing the amputation means we are not only saving the foot and limb, but now we are, knock on wood, we are hoping to give her a number of years, so hopefully she doesn't have to go through this cascade of mortality. Thank you so much.